Very good afternoon, and thanks to our teacher and Madhusudanji. Thanks for being there.
Thank you for the case.
Thank you, sir.
Thank you,
Uh,
sir.
she is a 35-year-old lady living in a developed country with her husband and two sons in third grade and first grade. The patient was educated up to MSc B.Ed and worked as a teacher at a high school teaching maths and science. Her parents, brother, and parents-in-law, brother-in-law, and his wife, they lived in Western Indian cities. The brother-in-law was subsequently with the patient and her family in the developed country, in a Gulf country, whereas the brother-in-law's wife, husband's younger brother, his wife, she continued to live here in a Maharashtrian city with her parents-in-law. Essential clinical features will include patient was accompanied by her parents, brother, and husband, who provided most of the details as patient was not in a state to engage in a meaningful conversation. She seemed to be in a trance-like state with her eyes half shut, hands held awkwardly high, folded elbows, and palms facing upward while moving repeatedly as if asking for grace in a prayer. With uncontrollable shaking of the body throughout, she was mumbling monosyllables or repeated phrases such as enough, enough, stop it now, continuously, and was talking only after being prompted several times. She was apparently doing well after initial treatment with a psychiatrist in Pune until the day prior to the first visit to the treating clinic, that is, my clinic. She and her husband had traveled back to their homes in India for a brief visit, and these behavioral complaints had obviously extreme misery they had started. The patient reported being preoccupied and having repeated assuring thoughts of the well-being of her mother-in-law and other in-laws back in India, and an unexplainable fear of death in response to the obsessive doubts she had about the health and welfare of the in-laws. She said she would prefer to stay, uh, just a moment. She said she would prefer to stay with them but had to return to her country of their voluntary migration. I am taking care to avoid naming the country and the migration and all that. She lived in Dubai between all of us. Yeah, just a moment. Please allow me some 1 minute. Sorry for that. And then uh, unexplainable fear of death in response to the obsessive doubt she had about the health and welfare of the in-laws. She said she would prefer to stay with them in Dubai, but had to return to the country of their voluntary migration, lest the education of her sons would suffer. Her parents brought her to their home, but she continued to worsen, lost her appetite, and subsequently stopped eating completely. Her sleep and self-care were impaired. She was taken to visit their regular family doctor, who supported the patient and family emotionally and prescribed medications for her insomnia. She became very drowsy and showed no symptomatic improvement. The family could not provide any clue toward a probable cause of her symptoms. She had a history of a previous episode of depression, which was treated by the psychiatrist mentioned above, but the episodes would keep on repeating. For the current episode, a working diagnosis of conversion dissociative symptoms in an adjustment disorder with anxiety depression was made. Conversion symptoms subsided quickly after the first two sessions of about 60 minutes duration each. Considering the current intensity of depressive symptoms, very high anxiety, and concurrent regression, she was started on I give low dose
Sorry, low dose?
psychotropics.
Huh.
She was given lithium 75 milligram per day, lithium carbonate, olanzapine 5 milligram a day, prothidine, that is dosulepin, 50 milligram per day, and escitalopram 5 milligram per day, and clonazepam 0.25 milligram a day. It's a combination of antipsychotics and antidepressants. Only one antipsychotic, olanzapine, in 5 milligram. I was continuing and tapering the doses from the earlier doctor and changing to whatever I preferred. There was a dramatic response to the treatment, including medications, in the first visit, following which we took her sociocultural formulation interview. It was planned online, but it did not happen as the patient returned to their country of work, and we could not do that yet. The transcripts were read and reread to understand the domains covered and the depth and clinical relevance of the elicited information. And then the clinical interviews, the information that we got, we put it under domains. The DSM-5-TR diagnosis and subsequent working through were described like this: that there were relationship disturbances between in-laws and the patient, husband and the patient perhaps, adjustment disorder, conversion dissociative symptoms, anxiety and depressive symptoms, and she needed a certificate. So a certificate was issued restricted to the diagnosis of adjustment disorder with anxiety depression. We did not mention other issues so that we did not want to disturb the family dynamics further because of our certificate. Possible family discord and deeper representative conflicts could possibly be addressed in the future. Patient symptoms, ironically expressing weakness and vulnerability, actually helped her to master the situation that could have led to more complications due to the obvious structural violence. I will explain what I mean. We we thought that the patient is a very religious lady who prays frequently for others' well being. Being religious with high morals and being a mother are the most important features of her identity. Though the cultural identity is of crucial relevance in this case, most of its substance was implicitly understood and acted upon by the clinician and the relatives in tandem. Nobody put it into words and got it confirmed. Illness explanatory model, it elaborated and unfolded quite well. Patient's father reported that the reason for her troubles possibly was fear and restlessness when the clinician gently and empathetically inquired if they were considering the possibility of seeking a religious consultation. Then they said it was fear and restlessness. Asked them about
Can you say it again? It's lost in the network. Uh,
I gently asked her, empathetically inquired They were considering the possibility of seeking a religious consultation. The family was visibly relieved. They voiced initially hesitantly, but later fluently and in a relaxed manner that yes, they had consulted the relevant healers already. Many conceded to a prompted question if she had discovered if she had if she might have suffered an evil eye from someone, also reporting to having discovered Nimbu Mirchi, lime and chili outside their house regularly for several days. Patient echoed these emotions but also seemed frightened and whimpered when the doctor asked her, did someone criticize or do something like Karni kind of black magic against you? And then she whimpered and said yes. Furthermore, the patient reported a young unknown boy
Can you, sir, can you say it again? It's lost in the network. She repeated, young unknown boy.
reported that during her honeymoon, a young boy unknown to up to her
Sorry, young boy. Uh, it's not audible again.
Sir, there's a problem with the equipment, I think. We are losing you again and again.
you have any suggestion, please tell me.
Uh, During the honeymoon, a young boy.
Everyone up to them.
Uh, I think there's some issue with the equipment. Uh, Maybe the wireless is not working. Maybe something wired can work. Because I had a similar issue with the wireless thing.
Try this way.
Yeah, much better.
Okay, okay, good. So the boy ran up to them,
Uh,
ran, and said that her marriage would be ruined by two women, a fact that she does not complain about but also has not forgotten. The ambivalent belief in cultural magico-religious magico-religious causation of the symptoms due to negative feelings of others is obvious through the lime and chili and a stranger boy foretelling the ominous fate of the patient's marriage. The swift and in depth evaluation of the clinical, psychiatric, and sociocultural contexts and attention to structural factors in consonance with prevalent culture were all instrumental in the dramatic recovery. We, we first of all showed to them that considering culture specific disorders was not wrong or bad or abnormal. We also diagnosed the evil eye, and it was
we also diagnosed.
evil eye,
Right.
बुरी नजर.
Hmm.
We obtained further information about key social relationships. The husband feels that their marriage is going well and there are no issues. The decisions regarding her career will be taken under the influence of the family. The husband clarified that she does talk freely to express herself and raise questions about their decisions. She is comfortable with her parents. Her father reported that she can and does discuss with them her marital family, while in the biological family, due to the differential respect regarding the in laws, she respects her husband too much. The family agreed serious issues between the patient and the mother in law and the sister in law, the husband's younger brother's wife. When the doctor pointed out that the patient's younger sister in law had not yet received gratification from her marriage, in contrast to the patient living with husband having two sons, while the sister in law lived separately from her husband, even though Her marriage was fresh and had no kids and could not live in a developed country. The patient instantly agreed to this possibility. When we suggested that बुरी नजर इसकी वजह से हो सकती है, that she had got everything and the sister-in-law didn't get anything, the doctor considered the possibility of the patient having suffered from an evil, perhaps from the dissatisfied sister-in-law. She was tearful while talking about her family. In addition to the intuitive and insightful understanding of the patient's life situation, the accepting, inclusive, and forgiving attitude to perceived negative feelings of the in-laws perhaps helped this astute lady of genius talent to take the negative things in her stride and calibrate the family dynamics.
It's lost again.
It was quite all right to feel negative
Ah,
the relatives.
sir, it's lost again. Hello.
So we can't hear you.
उसको बुरी नजर लग गई थी
Ah,
and that was because of her that led to her aggressive feelings towards her in-laws.
right,
And when we said that it is okay to feel anger toward them because she was having the evil eye, buri nazar, he
right,
was relieved. Okay, the family environment can be regarded as manifesting benevolent patriarchy because they were allowing her education, but not the job. She could not work there. Here she could work, and she was qualified. Generally consistent with the family-centric Asian culture. Parents of the patient reported being very hesitant and skeptical. Hospitals in general and have high anxiety surrounding the ICU, thus not willing to admit her to any hospital. She was taking treatment from 2023 onward for depressive episodes.
hmm,
Upon using these socio-cultural interviews, who was enhanced. The patient smiled freely and was satisfied with the outcome of the discussion with the doctor. All the family members had a positive evaluation of the intervention, especially her brother, who repeatedly admired. These questions are very powerful questions. Did you know that it was this family constellation and dynamics causing this phenomenon called Puri Nazar in this patient at this time?
right.
Is, is that
We can't hear you.
you on mobile? Shall I take the call on mobile? Try that.
Ah, perfectly fine.
Okay. No, just a moment. Yeah. I'm trying to connect my phone.
Yeah, please connect.
You admit me for.
Yeah, I have admitted.
Hello.
Ah, sir, please go on.
Can you admit me in the room?
Yeah, of course,
I
sir.
am already.
Huh?
Yeah. I'm taking it from the phone now and I'll read the transcript from my computer. Is
Huh.
it better? Does
Yeah.
it work better? Okay. Okay. So as I said, the relatives were very much positive about the interview and the questions. It is worthwhile to note and understand the admiration of the patient's brother regarding the interview questions and their efficacy, considering that his son is a super specialist surgeon working and settled in the UK. The barrier from the supposed rift, devaluation, and stigmatization of religious healing by the practitioners of modern medicine was as if dissolved. They were defensive. They thought that doctors, modern medicine doctors, will look down upon religious healing. And when we took that factor away, they were visibly relieved. Its putative causation and the doctor's non judgmental acceptance of the pluralistic therapy, networking of modern psychiatric and traditional cultural approaches was acceptable if it would not cause harm to the patient.
Hmm.
In an interesting development after the socio-cultural formulation that we prepared, it was shared with the patient's family. They swiftly arranged for the younger sister-in-law of the patient to migrate to the city where patient's husband and brother-in-law had worked. They did not tell us that. They just said, I handed it over to them and told them that I want to report this case so that doctors know that networking between the modern doctors and religious healers is okay if it is not harming the patient.
Right.
And they said, okay, we will do that. They kept it with them for almost a month or so. I thought they have dropped out. They will not consent. They returned it and they said, we just changed one sentence in it. You read it. And then when we read, we found that they had said they had sent the patient's sister in law to the country where the patient's husband and brother in law also worked. And now the new couple also were staying in the next building to the patient's own family. So, the younger couple also could unite in their early post-marital life. This was a masterstroke by the family. After evaluating the clinical cultural interpretation, they were liberal and progressive to take the corrective measures. It should be noted that the clinician was frank to admit to himself and the peers, yes, initially I did feel a pang of pain, you can say. I temporarily felt that the treatment was taken away from me. They got the diagnosis done and decided on the next course on their own. Okay. And later on, I realized that actually this is what was ideal, that patient participation in the treatment and their autonomy is what I should have respected, and I did.
Right.
So it happened behind my back and without my knowledge. It should be noted that the clinician was frank. Okay. Once the family had the diagnostic and for socio-cultural formulation, only to realize that this was the best example of patient participation in treatment. Interesting things were it was over only in 3 sessions.
Uh-huh.
The duration of the sessions progressively decreased from 60 minutes to about 30 minutes during the 3 sessions. When the rapport was excellent and all the necessary information was shared, as they say in classical psychoanalysis, that patient and therapist uh, they are silent in unison, something like that, akin to that, not exactly that. At the end of the last interview, the patient requested the relatives to wait outside in the waiting hall. She sent them out. I did all the sessions in front of everybody so that patients from a sensitive culture should not find that their lady is talking to the doctor alone. And it was initial first couple of visits. And she was also showing trance-like things. I did not not want anything. I was being a little defensive, you can say. End of the last interview, the patient requested the relatives to go out and asked the doctor. She asked me, on these small doses of medicines, is it all right to conceive the medicines that you are giving? So she was thinking and planning the third pregnancy
Correct.
and further emphasizing and explaining her cognitive, emotional, and social interpersonal recovery. I take it as a sign that the recovery was complete. Again, being the elder sister in law, she rightfully perhaps had to have a child along with the younger sister in law and more number of children and all that. The patient in this situation is a redeeming example of how structurally restrictive and coercive contexts, where calling it out would be rebellion, they could be resolved with deft and precise yet sensitive role played by her culture specific psychiatric symptoms. Symptom comes as a solution in conversion associatism that show an example of cultural competence on the part of the patient. It was cultural competence rather than asserting and fighting with the in-laws. She had symptoms. She became vulnerable, sick, got sympathy, help from the doctor. Earlier doctor would keep on giving antidepressants and for 2 years, since 2023 she was having symptoms. They would keep on recurring. Nothing wrong. He shared all his details with me. He was also very cooperative,
Right.
the earlier doctor.
Uh-huh.
And he was a friend also. This is a small place and we are a small community. So they all of them they know me perhaps. And that was all right. Overall, this approach was very effective. The use of socio-cultural formulation. This helped to improve the therapeutic alliance and an insightful, almost intuitive understanding of deeper psychological conflicts in the context of the family, community, financial disparity, impetus for growth, while preserving the family cohesiveness. The case highlights key cultural influences on psychopathology and rapid recovery and a good prognosis for this patient and her family across geographies and cultures.
Right.
And then I have notes from the earlier doctor from March 23, which are perhaps not very relevant here. So I rest my case here.
Any reflections, Madhusudan, on this?
Sorry, sir.
Hey, I was asking Madhusudan if any reflections on this.
Uh-huh.
So I find it really amazing that uh, Dr. Vasudev could think of this as an alternative to cure the patient. Because our natural tendency is to react against any semi-superstitious beliefs. So, and it worked. It's amazing. It's fantastic. I don't have any experience much, but I think this is a very unusual approach. I think that Dr. Saab has taken. Yeah.
Thank you, sir.
Yeah.
So, how would you put the, uh, if you look at two parts, the diagnosis and the pathogenesis and healing, three parts if we focus. So, let's say first we are looking at diagnosis. So, I believe you had put depression, anxiety, and conversion related
Yeah.
disassociation.
Yes.
Uh,
Yes.
huh. It,
Mhm.
I mean, was psychosis somewhere in the picture?
No, if at all, then I would say that this belief that the boy had run up to me, predicting the future that your marriage will be ruined by two women, then the black magic is being done by my sister-in-law and mother-in-law. they're mixing something in my food and giving some religious healing potions, which also might contain something. That is what was reported in the earlier doctor's notes.
Right.
This time, the relatives were all overwhelmed and busy idealizing the current treatment and how swift it was.
Right.
So, sir, why would we not categorize this as some sort of borderline paranoia on the
Uh-huh.
verge of psychosis? I mean, why would we not think of that first?
Because this is a very much culture specific disorder that is known, and the conflict is also representative and universal, and the explanation of evil eye is also very much in vogue. So apparent psychotic symptom need not necessarily lead to the diagnostic category of psychosis.
Okay.
What I believe is we are many times misusing DSM and ICD, or they want us to misuse them like that. I am rather going on the conspiracy theory side, that they don't let us allow sufficient psychotherapy for a person with delicate mental health. Maybe she was going in the direction of paranoia. Maybe she would have gone in the direction of, say, suicidal depression. But if we support well in good time, then the orange signal converts into green, and
Correct.
small doses are sufficient, and it spares them, it saves them of the stigma.
Correct.
Otherwise, their career of a mental patient starts
Correct.
and life gets distorted.
Correct. Uh, uh, did the OCD somewhere come in? Hyper-religiosity?
Yes, sir. And her belief that no harm should come to my mother-in-law, my sister-in-law, and she was of those obsessive thoughts that some bad will happen to them. That actually made her to pray for the God all the time, making dua. And when I interpreted those movements and asked her, "आप दुआ कर रही है क्या दीदी?"
Uh,
She was visibly relaxed. She said yes. एंड देन आई सेड कुछ किया है कि नहीं, बाहर वाले को दिखा है कि नहीं, मौलवी को मुजावर को वगैरह बताया कि नहीं. Then there was a silence and a suspense, and then with a visible sigh of relief they said yes, that all was done, and they had told us in the past that you consult doctors only. And then when I said it's okay, buri nazar is common, and then they thought that the doctor is on their side and not on the antagonistic side.
So then, sir, all that passive aggression towards the family, all that we don't need to consider in such a situation.
Uh-huh.
I'm asking, sir, like typically we would think of, oh, this is all repressed anger towards the family and the culture. And
Yeah.
so, but we don't need to bring it into the therapy in such a situation.
No, but psychopathologically speaking, it was there in the unconscious. Everything was brewing with repeated. The volcano was erupting from time to time
Okay.
and then getting pacified. Every year she would come and visit Mumbai, and biological family was in Pune, and the brother's friend was the doctor, family doctor, who had worked under me as a houseman in a private hospital 20 years ago. So that was a revisit. Actually, we met on phone only, but we connected after 20 years. He said, "Yes, doctor, I know you. I have worked under you and all that." So it was all very positive. The positive opinion about the doctor is also.
sir, you are muted.
Sir, we can't hear you.
Sir, we are not. Ah, ah.
Sir, you're not
So
audible.
this was a good case
Okay.
according to us.
Yeah. Now we can hear you. Please go on.
Sir, and if you are, I feel encouraged. If you are interested, I would like to share one of our papers and request that all of us could write case reports together based on your insights and the valuable things. And
Sure enough, I think. Please do it.
yes, sir. If you have, or Madhusudan sir, if you have publications, let me have them. We'll share them. And
Sir, I am into theory. I have not practiced so far. So,
but theoretical papers are very important.
yes, sir, I'll think about it. I haven't really published anything. So,
Uh,
yeah.
I have not
but
been much
we
in the
can.
I have not been much in the paper circuit. I have largely been in the book
Uh-huh.
circuit.
Okay. Okay,
But
they are great.
we can take a look because we can do it, not an issue. Please share it.
Yes, sir. I intend to do that now because I am becoming a little pessimist about getting funding for a long-term project now. Looking at my age, they hesitate while giving me some funding. Otherwise, we could take up a long-term major work also, where psychoanalytic perspective could be one aspect, cultural is another,
Correct.
and biomedical psychiatry is another. All these they enrich our branch,
Correct.
so we could do that. Yes, sir.
In fact, in one of my series, DSM and psychoanalysis, this is what I tried to do,
Yes.
that you take up a disorder, you apply all
Uh-huh.
the schools of psychoanalysis, and then you also bring in the Eastern part,
Yes,
and we can add to it the cultural part, like one more window to look at the same thing.
that will be good.
It's like in homeopathy, they have a very good idea
Yeah.
that the core difficulty in homeopathy is to select the remedy,
Oh, yes.
because the first thing they have is materia medica, and often
Yeah.
materia medica will lead to 3 to 4 remedies of the same time for the same problem. And then how to do the elimination without doing trial and error of everything. So they have different approaches like miasm, uh, kingdom, sub-kingdom, class. So the idea there is very interesting. They say that imagine the remedy is sitting in the center of the room, and the room has 7 windows. And if you open the window of materia medica, you see remedy R1. If you open the window of miasm, you see the remedy R2, then it's not done. But suppose you open all the windows and you see the same remedy R1, then the chances of it being correct are very high. So we can
Yeah.
look at a psychological issue in the same way. Okay, let the issue be in the center of the room, and you open the window of psychiatry and you see something. You open
Yeah.
the window of Freud and you see something. You open the window of Indian psychology and you see something. And when there is a confluence to the degree possible, the chances of it being right are more. Or if you don't see the same thing, but let us say you see the different things and they collectively complete a picture.
Yes.
Either of the situation, this idea of the problem being in the room and we looking at the problem from different windows, it's a very good idea.
Secret sits in the middle and knows. Something like that is a
Correct.
phrase, no?
Correct.
Mhm.
Um, this uh, just one curious question, and then we can get
Yes.
into the analytic component.
Hmm.
This type of situation that the patient is just not able to say anything, and
Hmm.
all the information is provided by the informants.
Mhm.
This is a very difficult situation to really be in, because
Yes.
many people will just diagnose it to be something not yet ready for therapy and say, okay, put on medication for a month, and when the person calms down and is ready for therapy, we get into therapy. A very normal approach.
Yes.
So,
Yes.
sir, how did you skip that trap?
I think non-verbal communication is very important, and when you get those gruntings and accents and eye movements and neck movements, and you register them, and the softening of the facial expressions, it was not that difficult actually. I tend to uh, I'm sorry, I tend not to be very puritanical and let the patient voice. And I will not provide any clue, because I have suffered due to that. In the beginning of my practice, I used to see a mother of my patient, my friend, my classmate. He is also a doctor. His mother also is a doctor. And she had a grouse against me. She voiced after 4 months or so. She said that because my son is a doctor and you are his friend and I am also a doctor, you cannot charge me fees. That is why you are not giving me any interpretation. You are not, you know the solution, but you are not giving it to me.
Oh,
And I had a tough time. I told her, "Look, ma, my mind is clear. I was just trying to go by the book and not providing any directive solution or interpretation." And then subsequently, 3 4 years later, because she would get somatic complaints after Vipassana, and they continued on and on. And she would discuss all her matters with me. And when I told her, she mentioned 3 4 years later that on some matter she would consult her husband's sister. Husband is dead long ago. एंड हस्बैंड सिस्टर सो ननंद से पूछेगी. मैंने बोला, मगर आप तो उस ननंद में विश्वास नहीं करती है. उसने बोला, तुम्हें कैसे मालूम? मैंने बोला, आप ही ने तो कहा था.
हाँ,
वो बोली, उसको तो इतने साल हो गए मैंने कहा हुआ.
हाँ,
आई सेड, बट दैट इज द डिटेल ऑन विच आई वर्क,
हाँ,
so I attend to such things. And that remained in my mind. She said, yes, that is perfect. And then the therapy proceeded without any problems. So I believe that modifications according to the setting and according to the patient's anchor point
right.
or location is very important, and that is where the cultural approach helps me.
Uh, this trance kind of situation, didn't it lead to consideration of uh, depersonalization kind of thing, or was it a different kind of a trance?
No, we did not reach up to that. And she did not say any time that I don't feel myself or something around me is different. No, she was very much in her senses. And since the beginning, she wanted to return back to Gulf, because otherwise her children's education would suffer. So she never came out of the role of the mother. That was her very cultural identity dear to her heart. And she was a feminine mother figure, which was very important for her. And that is what I suppose allowed her to tolerate all the criticism from the mother in law, favoring the younger sister in law. Younger sister in law was perhaps from the among the relatives of the mother in law. And this lady, even when she was living in Gulf and was higher educated, she felt a kind of seconded, and that's why she had those grouses against the mother-in-law, and that aggression led to fantasy might have led to fantasies of harm to mother-in-law and sister-in-law. They became obsessive, and therefore she had to do this prayer in a compulsive fashion. And to ward off her aggression, this is what I learned in fatigue weakness, that most of fatigue weakness many times is defensive, otherwise the person might become very aggressive. It is a what do they call? Uh, Protest. The meaning of that fatigue weakness is protest against the system.
Uh,
So she was
yes,
expressing at the same time not expressing. It is very much like psychoanalysis.
correct.
And even cultural approach does the same thing, that we take everything verbatim and put down everything like it is, as it is. And these days, as it is, there are very I would say the instincts are not very much hidden,
Hmm.
and they are in fact flaunted
Right.
by the newer generation. So even the devaluation and aggression, so not much of passive aggression, it is all open aggression.
Correct.
So,
So just as one of my teachers used to say, कि
uh-huh,
our father's generation was a super ego generation.
yeah,
Our generation is an ego generation, and the new generation is an id generation.
yes,
So,
yes, sir.
uh, what you said is very important. Like in ISTDP, also it comes up and it's recorded on video. So, if somebody wants evidence to do evidence-based medicine, the
Yes.
ISTDP is a kind of evidence-based psychotherapy because you record everything and you see, okay, to intervention X, why was the response? And to intervention Z, this feeling happened. That is there. Now, one important point there is key what you said. This fatigue is often comes in the form of sleepiness.
Mm.
So there
Mm.
is a fatigue which comes. There can be fatigue or there can be sleepiness. Now the sleepiness is a way to switch off the whole system
Mm.
so that you don't have to encounter difficult feelings coming in from inside, and mostly they are related to anger. That is one. And the second important point is where the therapist starts feeling sleepy.
Mm.
And when therapist starts feeling sleepy, it is usually hatred put into the therapist.
Mm.
That the patient is feeling hatred towards somebody not acceptable, and it's put in the form of a projective identification into the therapist,
Mhm.
and that causes sleepiness in the therapist. And
Mm.
many people who are not trained adequately, they actually doze in the session, and the patient takes it very aggressively.
Yeah.
That you are just not interested and you're sleeping as though I am boring. This is a kind of disinterest, a kind of attack, all sorts of things. And many people they stop coming because they see the person dozing.
There was one comment by one of my patients, and it was put on the Google also, where they have said that his fellow, I will never recommend this one to anyone because he dozed into the session. I might have dozed. I don't remember. I might
So,
have returned from a trip, and
so
my I
the,
might have had jet lag, and I don't know. That might have happened.
I did not know initially how it happened.
Uh-huh.
And many times, some of my patients told me, "Are you feeling sleepy?" Fortunately,
Yeah.
we were not attacking types because therapy
Yeah.
was long enough. So they could never think I was disinterested or
Hmm.
attacking them in some way, but they mentioned it to me, "Are you sleepy or something?" They don't know what to do
Most,
about it. Sorry.
most of the times, our patients are very forgiving, accepting, accommodative. They
Correct.
are very kind people, actually.
Correct. But later on, when I realized what to do about it, that
Hmm.
the way out was to interpret it.
Hmm.
That the moment you start feeling sleepy, you ask the patient, "Are you feeling hatred towards somebody?"
Hmm.
And many times I put a loaded question to say, "Towards whom are you feeling hatred right now?" Yeah, you're asking whether you're feeling it or not. You don't give him the chance to deny.
So,
Yeah.
sir,
I know it. You
in
just tell me
connection,
who is it.
sorry,
Yeah, yeah. Please go on.
that reminded me, sir, of something that I recently I did. There was a very, I'm a professor, so I have lots of classes in different places. So, uh, one of the students, she insisted on coming late every day. And she would come late and she would sit at the back and she would keep yawning and stretching. So one day I just asked her that, I just told her that you seem to be angry with somebody. That is not me. So the next day her attitude to the class changed.
Correct.
Fantastic. One session recovery.
One
Yeah,
interpretation.
absolutely.
So this is where the projection is broken,
Yes, sir.
that the transference is interpreted, and that puts an end to that process of transference. So either it goes off forever, or she has to find somebody new. So in analytic language, we call it the attack on the frame.
Mm-hmm.
When somebody is late consistently,
Mm-hmm.
it's an attack on the frame of analysis. So
Attack on the frame
frame of analysis.
of analysis.
We'll go into the definition of frame, what we call a frame, but that's a very important element, that there are two ways the attack comes. One is in terms of not paying, and second is in terms of coming
Coming
late.
late, not following, being passive aggressive,
Correct.
paying lip service.
So these are like attacks on the frame, because the core issues of the frame are, okay, you will come at a given time, at a given place, on the scheduled day every week. The second is you will pay on time whatever has been agreed upon. And third, you will speak whatever comes to your mind and
Yeah.
sincerely work on yourself. That's it.
And
These
not act.
huh,
And not act on it.
are not act on it. Reflecting, not acting. So these are like the four defining givens of the analytic treatment. So this is one part. And second, what you said, you also practiced here, is something we'll come into the technique part, the session length,
Mm-hmm.
because you shifted from 60 to 30.
Automatically happened.
Yeah.
I many times feel that I don't have my hands on the steering wheel. It is governed by the patient or the other factors.
So it's very intuitive and on the spot, very spontaneous, but there is
Yeah.
a huge amount of theory in psychoanalysis upon it.
Mm-hmm.
And in fact, Lacan was thrown out of the psychoanalytic society because it
Mm-hmm.
is what he called the variable session length.
Mm-hmm.
So for him, termination was an act of interpretation. That when you practice variable length and you terminate at a given point, that termination is an act of interpretation. But we'll come to it. What are the pros and cons of a given static variable, static session length and a variable session? We are nearing 3:30. Should we break for 10 minutes for a cup of tea and reassemble?
Sir, I'll have to leave, so I can't attend the rest. I'm sorry.
कोई बात नहीं.
Yeah.
We can catch up with recording part.
Thank you, sir.
Okay.
Thank you.
If we start with your idea from a cultural point of view, how would you state the cause of a difficulty, and how do you think it got healed?
In this particular case, uh, cultural perspective actually entails what the patient and the close ones perceive as the cause. Perceived cause is an explanation or is a meaning given by the patient and the sufferers to their suffering. So the causes can be legion. It can be biological, it can be psychological, social, or cultural as supergroups. Cultural can be traditional or cultural can be cultural physiological. Vata Pitta Kapha is physiological. Traditional cultural is like uh, past bad deeds, past life, karma, or Plutona,
Right.
and that. And social could be like financial adversity, romantic failure, academic failure, then class struggles,
Right.
poverty, and all those.
Correct.
Psychological could be personality, my nature, stress, loss, shock,
Correct.
and those things. Uh, and biological could be various like ingestion, खाने में कुछ दिया है
Huh.
या एक्सीडेंट, इंजरी, सर्जरी, virus, anything. Biological could be anything. So whole gamut of spectrum of causes they can consider, and they will keep on coming with various causes in different stages of the illness.
Right.
So our opinion doesn't matter. That gives us an opportunity to let the patient voice his views, and if they keep on changing, if perhaps his views become more mature and egalitarian, then that is better. Some of the causes like envy, jealousy might indicate more regressive and uh, base emotions with which the patient is afflicted.
Right.
There might be conspiracy theories, political explanations, vendetta. There may be real life stresses. So, all that.
So in this case, what do you think healed the person?
According to me, acknowledging that the younger sister in law had not received any gratification from the marriage. She could not get to live in the developed country, whereas the elder sister in law, who already had two children, still continues to live in the developed country with her husband, and here she lives separated from the husband. Her husband is the younger brother. He keeps working in Gulf and she lives here in Mumbai with in-laws, no matter how relatives they are. So they're still in-laws. And she did not have any gratification. So the doctors acted only as a catalyst. The father and the brother of the patient were more accepting. Husband was rather aggressive and more radical. But the father and the brother, they accepted what happened. They were amazed how the doctor could arrive at it in one session and how the questions were powerful. And then once they understood what happened, I don't know, there was a period of silence from their side. They must have had meetings over that particular model, explanatory model, and whatever was acceptable to their identities and the religious norms and the cultural norms. They allowed the daughter-in-law to go and stay with the husband, which means the elderly parents-in-law lived alone over here. But they were fit in that sense still, but the capacity, the readiness to lose their own power might have healed her. Apart from there is no longer any negative feeling coming to me. I had worked with a religion professor of religion from Germany and lived in stayed for 2 days in Unnava at a dargah. Which dargah it is, I forgot the name right now. Mira Ali Datar. Mira Datar. And I worked with her. I gave subtitles to her film and Dawa or Dua. That was the project on which she worked. So networking I was aware of, and she pointed out my mistake when I said I called something as superstition. She told me, Vasudev, you don't have right to call other people's beliefs as superstitions. So I learned from her, and nobody wants negative feeling from the other person coming toward us. So that is the thing that is most to be frightened of. So that was what disturbed her, and that is what healed her when that was the reason was taken away. This is my understanding of the case. And because they were relatively progressive kind of Muslims, they allowed all this, they entertained all this.
So let us say the fact when you pointed out that she has got good things of life and her sister-in-law has not got them, and that allowed the father-in-law and the mother-in-law to allow the
Yeah,
sister-in-law to go and be with her husband.
yeah.
So that changed something.
Mm-hmm.
And similarly, the second point was of accepting her religiosity.
Mm-hmm.
So this too
Mm-hmm.
is something that operationally has happened in the outer world.
Mm-hmm.
Now, if we want to go with this into her inner world,
Mm.
if we want the process knowledge of these two phenomena,
Yeah.
that in process terms, what would have happened in the inner world,
Mm-hmm.
that these two outer world phenomena brought about a healing.
Mm-hmm.
So if we go into the inner world, uh, one thing that we get is that uh, the boy, he comes to mind, who said, "You will be ruined by two women."
Yeah.
And here is
Yes.
the exact thing of the mother-in-law and the sister-in-law.
Yes.
And one of the two women goes away. And in the absence of that woman, the woman who is left behind, she also mellows down. And that, I think, is one big social change factor for her.
Power equations.
Correct. That the the oppressive coalition is dismantled.
Yes.
That the leader of the oppressive coalition goes away, and the follower who is left behind has no choice but to mellow down and make up and make amends and make up with whoever lady is left in the house. So it is like the teeth of the tiger has taken out.
Teeth of the tiger are taken out.
So tiger is now practically a quarter tiger, no longer a full tiger. And who knows if in the absence of the teeth, the tiger turns into a rabbit. You never know.
Yeah, she realizes her dependency on sons and daughters-in-law.
And the second part that we can also look at is that uh, the difficulty with the mother-in-law. Now, traditionally, it's very common to have the mother-in-law and sister-in-law ganging up against the daughter. It's very normal in tradition. And the second possibility, which we would just like to explore in process terms, is how is the relationship of this patient with her own mother?
Mm.
Because one way to look at it is that this is common in society. So the moment she would know that I am going to get married in a house where I will have a sister-in-law who is resident, married but resident, which is a very uncommon thing, and a mother-in-law. And then the boy comes and tells her this, and it sticks into her mind. That is one way to look at it. That she had prior social.
The sister-in-law,
Sorry,
sorry, the younger brother of the husband was not married then,
correct. So that
but she was getting married. Yeah.
so then we can look at it in two ways. The knowledge that the younger brother is going to get married and I will have two women
Yes.
and they will gang up against me. This is what would have come to her by what the boy said. The second possibility is that maybe the relationship with the mother itself is not very good. And if that is the case, then the transference on other women can easily be done. Because the core point is any boy can come and say anything, you don't take it seriously. You take it seriously because somehow it resonates with something inside.
Yes.
And that resonates with something inside. So as we know, the anger towards both of these women, and then the moral counter wish as a defense, which
Yes.
becomes an obsession, is that nothing should happen to them, when in fact the desire is something should happen to them.
Yes.
So are we looking it as a standalone phenomena of the in-laws house, or are we looking at it as a continuing phenomenon right from days with the mother? That,
Ideally,
huh,
yeah. Please, sir. Sorry.
yeah, please go on.
No, ideally, yes, all should have asked, but they vanished. And even when I asked for the later consent and other things, or the planning of a session with the patient, that did not happen. They said now she's fine. So they actually removed the doctor from the family drama
Huh,
once the job was done.
correct.
So this is I would say, the uh, cultural phenomenon of idealizing the doctor when he is needed, maybe in COVID days, and devaluing once the need is over. In Marathi, there is a proverb. It uses the word vaidya. I'm sure you know that.
Yeah, please go
Garas
on.
saro, garas saro आणि वैद्य मरो.
Huh,
So that is, but I would not go to that extreme. I would still say that they were having a good working relationship with the doctor and fairly evolved personality strengths to keep the conflicts within the bounds, because I remember having read that perceived causes also change according to your emotion at that particular time. When you are feeling stable and in control, you may not entertain the more primeval causes, perceived causes. But as your own demoralization increases, your own mood goes down, you start entertaining worse and worse, more regressive causes. And that, in fact, makes the conversion from normal person to depressed person to psychotic person. And there were papers which said, I remember, I haven't checked in recent literature, trying to change the perceived cause, trying to change the belief about the causation of the illness does not actually improve fatigue and weakness. The symptom doesn't go away, perhaps because it has had a longer reiteration, the times before it has number of days and years it has remained. So that also must be counting.
Hmm.
But level of that is why the pre-Oedipal, this conversion and dissociation, was it Oedipal or pre-Oedipal? It was pre-genital, I would say.
Right.
It was not actually very mature kind of evolved conversion.
Right.
Like what Madhusudan sir was saying, that may be correct, that it was a primitive personality
Huh.
functioning. I am sorry, primitive borderline personality functioning, though not borderline personality disorder.
Correct. Correct.
But it may never surface again if she never is confronted or threatened
Correct.
with the loss again. And many of us live like that without being threatened.
Correct.
And only very few survive, even when they are threatened, they retain their integrity and grit.
Correct. So this becomes then the play of ego efficiency or ego strength.
Yes, sir.
How far can you take that stress
Hmm.
from outside or inside?
Hmm.
So, and what amount will cause what level of regression?
Hmm.
And that as regression happens, it goes on dismantling the structures. It goes if you go 2 years back, you dismantle the structure. You go back 3 years back again, dismantle the structure. So all the gains, because just as there is regression, there is also progression. There are also gains one has made over a period of years, and those gains are dismantled as you go back.
Yes.
And how many gains are dismantled and how early you go back?
Hmm.
That's very important. Uh, one aspect of this encounter can also be seen in terms of a safe, accepting authority figure.
Hmm.
That the projection of omnipotence on doctor and therapist is very common.
Hmm.
And when the projection happens and that person accepts you, then it's an acceptance by an omnipotent person.
Hmm.
And if the omnipotent person is safe,
Hmm.
then one of the things is you are able to internalize a safe, omnipotent person.
Yes.
And that is a very important element, that all previous omnipotent persons were not safe and accepting. And
Yes.
the moment she got it, probably one of the things which might have happened in process terms is feeling safe and
Mhm.
internalizing an omnipotent person.
Mhm.
That may, in process terms, be one of the elements.
Are you hearing the ringtone?
Yeah,
Just a moment. I'm called with a button. I need to rest. And this is what has happened because I am not very well versed uh, with the technology. I mean, sorry, where it is coming from.
it's gone now. It's fine.
Gone, gone. Yes, sir. But I need to remove that blind spot and work on it in the technology. Link to Windows. Okay, yes, sir. So, what I had to what I was remembering is that if I have a transference on to a therapist, which is positive, but because my parent figure was negative, and if the that original parent figure also improves and evolves irrespective of my therapy process, then does my transference toward the therapist also change?
Yes,
Uh-huh.
because the real life internalization of the parent figure undergoes a change.
Hmm.
Some people may still do it in the sense that something which has been on for a long time
Mm-hmm.
undergoes a change, but still there are certain things which were built up when the X entity was active that still continues, but the person will reflect upon it and say consciously that it's no longer so, but once it was so, and therefore I am still having this. But if it happens in early enough age or in a quantum that it changes internally,
Mm-hmm.
the internalized figure, because the internalized figure is very important, then it would change the transference to the therapist also. The
Yes.
second component also will be of, so there will be two parts. One, the difficult parts of the person in the real life and the limits of capacity or the limits of omnipotence of the person in real life. That
Mm-hmm.
omnipotent deficit will still create transparencies.
Mm-hmm.
So the transparencies happen out of many things, and one of the things that it happens out of is uh, unfulfilled desires. It happens out of difficult people in life towards whom expressions could not be done. And it also happens because of the deficit of omnipotence. It can also happen because of the functioning of the surreal, the dreamy part inside of us, the imaginative fantasy part inside of us.
So after sufficient maturity, a person might say, I understand my limitations, I understand my problem, and it is not cost effective to continue to work on them. So I'm not working on them. I'm pulling on with the handicapped leg kind of thing.
Yeah, so this is what happens in most serious cases, like severe cases. So if you divide all cases into mild, moderate, and severe,
Uh-huh.
most severe cases, what happens is we don't get 100% cure, but we get two things. One, we get a 75% cure,
Mm-hmm.
and the other 25% which remains has been diluted in intensity and known
Yes.
very well by the patient. And now the patient is living with a difficult friend. The friend will not
Yes.
go away. He's a long-term friend.
Yes.
But the patient knows what is the cost of it. And he knows that somewhere we have reached a dead end. That given the capability of medicines and therapy, we are where
Yes.
best can be.
Mm.
And now,
And there is little life left to live by now in future.
correct. So Laka uses a word for it. He calls it synthion.
Calls it
Synthion. Synthion.
Synthium. Yeah, I remember you gave us some video last time.
So it is like, it is a situation where the conceptualization where the symptom is separated from the suffering. That the symptom is not 100% gone, but it is not associated with suffering like a synonym. They are no longer synonyms.
Yes.
So the symptom continues, but its intensity has been reduced, number one. And number two, the suffering has been reduced of whatever per unit suffering was there. So now it's a difficult friend you are living with, you know the cost of it. And you know there is no separation.
Yes.
So
you cannot migrate from, say, Afghanistan or Pakistan to India now.
yeah. So in Afghanistan, you live in Kabul and you live in a good society.
Yeah.
You can't get citizenship of Canada.
Minimize the losses.
Correct. So in personality disorder also it happens that the last 25% of it, the person accepts that I have changed a lot of things in myself. I am no longer what I used to be by default before I knew anything about it. I have known a great deal, worked a great deal, reformed many parts of myself. Now what remains, I find it difficult to go ahead. And I know the cost of it. And I'm conscious about it. So where critical situation arises, I hold back myself.
I
Hold back myself.
hold back myself.
I don't allow that unconscious thing to run unregulated. So, but this is where it is that occasionally it makes an appearance. Occasionally I still act out of it. Occasionally I pay a cost. And somehow, even though I know cognitively the roots of it, I am not effectively able to undo it.
Perfect.
So this is where one settles. And Freud has a very good take on this. He raises a very important question. Therapy terminable or interminable?
Therapy,
Terminable or interminable?
terminable or interminable.
There's a very famous paper on this, and he says, at what stage should you think it's enough and the therapy should be terminated? And there are many ways of looking. It's a very complex question. When should we
Yes.
terminate therapy? So, should you look at absence of symptom? Should you look at a symptom and the patient being okay with it? Should you look at administering a statistical instrument to find out if it's no longer clinical? Should you look at cessation of symptoms, or should you look at personal growth also? In terms of personal growth, what do you put as an ideal? An ideal between the two of you, or the ideal put up by spirituality? So these are slightly complex questions. You're saying something.
I remember we having learned normality in our edition. I have a belief that person gets fixated like a still picture on the outside of the movie theater. When he passes his MD, he remembers those textbooks better than the other years, either before or after. So I remember the chapter on normality where they said that there are four kinds of normality: utopian concept, uh, clinical concept, statistical concept, and eclectic concept. And these are what you were telling me just now in the psychoanalytic terms.
Correct. Correct.
Yeah. And secondly, the original question I remember, will administering ego strength questionnaire or something like that, some test to get a working understanding of is this patient uh, ready enough to take on a work that is maybe frustrating or challenging or confronting, or is he unsafe for the therapist also? Whether the patient, is there any such tool that we can use in the practice?
Yeah, there are ego strength tools.
Uh-huh.
There are ego strength tools, but every tool will have limitations.
Yes, of course.
So as a guide, one can start off with that and see
Uh-huh.
what is the response to the type of intervention.
Yes.
And
Mhm.
it is where one can actually go in a more measured way.
Yes.
So the best test is the practice.
Hmm.
When you actually make that intervention, what happens? That is one. The second safe way to go about is, regardless of whether you use or don't use an ego strength tool, move from the lighter to the stronger. It's a very safe way. Like start from holding, go into an interpretation. If everything is okay, go into a harder interpretation. And then move to challenge, and then move to confrontation. The only thing we have to be careful in challenge and confrontation is that we don't get into a situation where you are challenging or confronting something in a situation where the person is identified with it.
Person is identified with
With that thing that you are trying to challenge or confront. Otherwise, instead of challenging or confronting the problem, you will be confronting the person.
Uh,
So, like, for example, let us say a therapist is talking to somebody who is in training or who is himself a therapist, let us say, or somebody who knows something about this thing. And the therapist in some way talks about a statement in psychotherapy which can have a different interpretation. And now the battle starts. That the therapist says X and the person says Y, and both of them are correct in the area of therapy. Now the best way there is not to get into a discussion academically, because a therapy session is not a conference. So we are not here to prove or disprove theory, we are here to heal. So the best is to drop that thing and not convert it into an academic dispute.
That is great.
So it's very, very important when people who are knowledgeable in the area come to therapy. Yeah, coming to our classical way of looking at it, from a Freudian point of view, one can also look at having got a good father. The same thing you can be interpreted. The girl finally got a good father. And the Oedipal desire in some way was met. But the Oedipal desire that we are looking here is not so much sexual, it is more emotional.
Absolutely.
That is one part. In pre-Oedipal terms, or even in Oedipal terms, we are looking at a very intense Oedipal rivalry and sibling rivalry. That Oedipal rivalry with the mother transferred onto the mother-in-law. And sibling rivalry when in her own family later siblings would have come. And that transferred to the sister-in-law. So we also look at those points from an Oedipal point of view, that the resolution happened in a way that the good father she got finally the good father. She also got rid of the sibling rivalry. And she also defeated the mother figure. So there is an Oedipal victory of having the father defeating the mother and having got rid of the sibling with whom the father was getting shared. And here you have an accepting father. And the acceptance of religiosity may in the unconscious mean her own acceptance. So this would be the Oedipal way of looking at the same thing in process terms. Okay. If you translate the real world events into an unconscious level events, okay, how do the real world events, which are macro and operationally tangible, translate into that esoteric unconscious level? And if the healing stays for a very long time, hopefully forever, then probably we would say at that unconscious level a permanent change has happened.
Yeah.
If we see a relapse, then we would say that the unconscious part is still difficult, not healed, or maybe the stressor in the environment is still active, and the social victory in the outer world did give her partial relief in the inner world and also in the outer world, no doubt about it. But in the inner world, some part remains to be done, and that would take us to probably a pre-Oedipal thing. But if they don't come back and we believe that it's done forever, then probably this encounter
Yeah.
has changed something very deeply into.
I remember Freud's statement. I suppose he wrote to Wilhelm Reich that it doesn't matter whichever school you use and whichever technique you use, but you must love your patient.
Correct.
Then only the healing takes place.
So one of the places Freud says psychoanalysis is a cure by love.
Oh, great.
So one of the places he says this, and he also says love is the force that only can tame the aggression.
Hmm.
When he talks about the two force theory, the eros
Yes.
and thanatos, the eros tames the thanatos by coupling. If we go into the pre-Oedipal component,
Uh-huh.
what pre-Oedipal components can we look at? One is an obsessive part driven by
Yes.
aggression.
Sorry, obsessive part
Driven by aggression.
driven by aggression. Yes.
And a death wish towards the two women,
Hmm.
which death wish can again be Oedipal.
Hmm.
It can be an Oedipal death wish
Mhm.
towards the two women. One for related to having the father, and second related to sharing the father.
But there is obviously no father figure was actually prominently discussed here. Neither father nor father-in-law. You mean therapist himself or the
Therapist,
husband?
a therapist.
Therapist.
Oedipally, what would have happened is a unresolved Oedipus would have been resolved by finding a good father figure,
Hmm.
which resolved the desire of the father, the uh, death wish of the sibling,
But
death wish for the mother, and they translate in the way of taking the teeth out of the tiger.
yeah.
In an aggressive sense, they are dead.
Hmm.
They can't aggress anymore.
Hmm.
The pre-Oedipal is the sibling rivalry, probably. The Oedipal rivalry, the pre-Oedipal sibling rivalry, and the pre-Oedipal component we don't know much, but if we know the relationship to her own mother and how
Yes.
the early 2 years of childhood went by, we can see it. Because one of the elements there we see is of uh, very, very strong morality,
Hmm.
which gets into religious terms.
Mhm.
The uh, strong religiosity, is it just to overcome the death wishes, or is the strong religiosity also a stable pole to hang by to counter the erotic desires? Because many times hyper religiosity is a counterbalance to erotic desires. That the more erotic desires activate in the unconscious, the more strongly the person holds on to religiosity. And that often is seen as a psychoanalytic mechanism working in the unconscious of the terrorists. That the more the bisexuality inside rears its head, or the more Oedipality rears its head, the more strongly religious the person becomes. And in some cases, the more the paranoia of the early life rears its head, the more religious the person becomes. But there is a difference in terms of the pre-Oedipal non-erotic cause of hyper-religiosity, you will see symbols all over, accumulations. Like one will have a mala, and then one will have a ring, and then one will have something else. You will have 3-4 elements in the body, I mean on the body. And you can also have tattoos which are religious in nature. And this is primarily a pre-Oedipal early life root of hyper-religiosity against paranoia of some kind, against attack of some kind. But when you have an erotic root of hyper-religiosity, then we see that in more in bisexual cases or homosexual cases, and in some cases unresolved Oedipality. And there one can look at the person himself. Okay. What are the fantasies? What are the dreams? And what is the general look of the person? And what is the transparential feel of the person?
Yeah, it is quite different. Mature transference feels different.
Correct.
Regressive people, full that appears feel different. I allow me irrelevant speech again. Free association. I had an intern with me who was Muslim by religion, and when parting, she gave me a gift of a piece of dari, carpet-like thing to sit on, which they use during prayer. And because I had some problems with my backache and all that, I put it on the pillow on my chair. And that lady is gone. That intern was gone years ago. And I'm still using it. And some Muslim patient came and she saw and she said, "Oh, but this is our prayer for this is a mat for our religious prayer." I said, "Yes, but that is what I'm doing when I'm seeing a patient. I'm actually doing a prayer of the God. I see God in the patient." And she was convinced and allayed her fears. And it is very nice. So many years have gone by and it is still very nice. I, I really, I really am dumbstruck by the kind of affection and love certain patients and students give you, and teachers, of course.
Correct.
They hold you to heart and close to their chest when you are going through difficulties, and this is amazing. Otherwise, survival would have been difficult.
Correct.
I'm sorry, I took you on an emotional ride.
नहीं कोई बात
But
नहीं, totally okay.
at times I feel that I cross boundaries. That's maybe one of my borderline traits, that I forget whether it is a class, whether it is a supervision session, whether it is therapy session, and all these things are new to me. When the new interns they come and tell me, I don't want to do clinical. I will go somewhere else. I want to see only non-clinical cases. I say this is ridiculous. There are no such thing as clinical and non-clinical cases. You should be able to heal even a non-clinical person. This is what psychology is about.
I would put it differently. I would not put it as a borderline trait. I would rather put it as a kind of a spontaneity
Yeah,
to
thank
go
you.
somewhere else. And I think there is an important call at the point. Okay, why there was a need to bring it up? It's a very important point to contemplate upon. It is like Freud uses a very good word for it. He calls it screen memories.
Oh, yes.
That suddenly out of nowhere you are into something and suddenly something flashes before you as a visual and you don't know what it means, but Freud says it is loaded with meaning. You just have to contemplate over it. That screen memory is loaded with meaning, and it has come up. That coming up also is very meaningful.
Yes.
So I would say it is that as we were talking and this came up, it is worth contemplating why it came up and why is it so important. So, like we ask the same question million times in psychoanalysis. What does it mean?
Yeah. Re-allegiance to the healthy teacher-student relationship, uh, repeating the commitment to your profession and your relationship with the patient, holding it the supreme most thing in your practice as a core of ethics. All these, they are the reminiscence of. That is why these classes become. They don't arouse tension in you. You feel free, and then you are accepted even if you cross the line. That is great. Thank you. This is where I am like a patient. So patients also are like that. And
Yeah.
when they do that, you accept them like a good father, they heal.
If we become honest, we are all patients.
Thank you. Yes, sir. This abstract, that way that I presented today, this case, is one of the two patients that I am submitting to a conference. There was a call by Society for the Study of Psychiatry and Culture, SSPC, where I had presented a plenary in 2015
Great.
about challenges in of practicing psychiatry in Pune. And after my talk, it was a hodgepodge according to me what I presented. But the retired presidents of the society, they called me. They were all standing in one corner, and they said, "You spoke well. That is one point, but you told the truth." Because I mentioned, they said your grandpa model was very interesting. I said, my teacher told me that you should be like a grandfather, and then you will be able to have ties with the patient which are not bound by transferential ties, and you will be looking only at the welfare of the client. And second is that the parents and the uncles and aunts of the patient also should look at you with respect. That is the meaning I glean from it. But otherwise, I am beset by inferiority feelings. I don't look like a doctor at all, and people don't take me seriously wherever I go. So it's okay. When it comes to the session, I deliver, and that's how I'm still in practice. They have kept me in practice so long. So this works. So I like that, and there our abstract is again accepted. This time we have submitted an abstract about socio-cultural formulation, the paper that we wrote recently, which I will forward the link to. It is an open access paper, and if you don't mind, I will put it on the group, or I'll send it only to you. And
Let's put it on the group. We all reflect upon it and let us see what everyone has to say. Something.
yes, sir. Yes, sir. Thank you.
I don't think you should be feeling inferior in any way. Um, you can import some narcissism from me, and I present it a different way. So when somebody
Next,
says, "Do you have it? Do you have a narcissistic personality disorder?" I put it different way. I say, most people suffer from narcissism deficiency syndrome. I don't have that problem.
great. This is something which I need to heal, but perhaps in the next life. I have tried so many years, and it's okay. Like you said, the old friend now. But I will definitely try not to put myself in a self-demeaning fashion, which Mitchell also always told me. Vasudev, you should not be doing that. All right, sir.
Okay,
Thank you. Very kind of you.
thanks.
Bye, sir.